It's 1:30 a.m. in Morocco now, and it's 8:30 at Guangzhou, China. Today, our guest is the distinguished Professor Guohua Zeng from Guangzhou. He's the head of urology department. Let me first introduce him. He completed his Mastery of Urology training in 1992 and his PhD in urology in 2000. He have done a clinical endourology fellowship at University of Texas Southwestern Medical Center in Dallas, 2007. He's an experienced endourologist with more than 15,000 endourological procedures, including all kinds of PCNL, rigid URS, and RARS procedure and urolaparoscopic procedure. He's a leader in China. He also designed with his colleague mini PCNL technique, namely Chinese mini PCNL. You performed more than 30,000 Chinese mini PCNL surgery with good clinical outcome. You invented a new minimally invasive device and technique in the treatment of mid-sized renal stone. You coined super mini PCNL, combining active irrigation and suction through the same sheath, which is totally innovative technique and a real revolution for mini perk technique. He organized and led more than 330 endourological stone management workshops throughout the world. And you have trained more than 3,000 Chinese residents and more than 110 international residents and fellow from 36 countries, including US, UK, Morocco, Egypt, Qatar, Kuwait, and several other countries. Your training that you provide in your center was certified by Endourology Society Fellowship Program since 2014. And you are a member of the Urology Division of Chinese Medical Association, and you are a member of editorial board of the BGU International Urolithiasis, the Chinese section. You are a regular guest and speaker at Challenge in Endourology annual meeting, and you have gained 5 research projects for stone disease from National Natural Science Foundation, and you have more than 100 academic papers in national and international journals, 10 books about stone disease to your credit. You published recently a book with Dr. Kamal Sarika from Turkey, percutaneous nephrolithotomy. We'll talk about it later. And you have finished a national survey of stone disease incidence and related risk, and you set up a normal value for 24 hours urine in Chinese population. As for basic research, you did focus on the relation between calcium channel, estrogen, and stone formation. Another outstanding academic achievement is the setup together with the Professor Zhang Conye and the Professor Kamal Sarika of the International Alliance of Urolithiasis, IAU, in 2012. This international organization is dedicated to research and treatment of stone disease. More than 450 urologists from 80 countries have become member of the IAU. And you have so far organized 8 meetings in China and on other countries, including Nepal, India, Turkey. And this year was supposed to be London, but because of the circumstances of pandemic, it was postponed. This organization provides an academic exchange platform for all stone disease doctors in the world. Professor Zhang, welcome to the Bridge in Science. That's a very outstanding achievement in your career. So, welcome.
This morning.
And we'll talk through different steps of this interview. First of all, China was the epicenter. It was this ground zero of this pandemic. How were you coping with this during this pandemic? How were you treating your patient? Is there any delay in the treatment or diagnosis of the patient during this particular period?
Actually, in this difficult and the challenges time, it's very, very difficult for every urologist to manage stone disease because of COVID-19 outbreak. Actually, at the beginning of this year, while coronavirus outbreak in China, maybe everything is stopped.
Now it's
and
okay.
yeah, it's stopped now. It's okay.
There is no lockdown anymore. No lockdown.
Yeah, everything is returned to the normal condition. For example, for example, now in our department, everything is normal. More than 20 or 25 operations was finished in our department daily. Everything's okay. Yeah,
everything is back to normal.
yeah.
Did it have any impact in delay during the height of the pandemic? There was any delay in delivering care to the patient? There was patient you have postponed till the lockdown is lifted? Any patient that you have to delay because of this pandemic? So, I mean, during the period of the lockdown, if you stop delivering care to the patient just in this particular period of time.
During the lockdown time, maybe most urologists cannot come to the clinic, to the hospital to see some patient who cannot do some elective surgeries. So most of urologists see patient is online and with APP, and then for emerging case, you must do it before the operation. You must check virus DNA is negative. You can do it's positive. You can transfer this patient to the hospital. Yeah.
Okay.
Maybe this is a little different from Western country, Western hospital. Maybe in China, maybe in city, you have maybe 4 or 3 designed hospital for this infected cases. Yeah.
Oh. I have visited your department twice in 2017 and 2019, and I was impressed by the amount of cases you're doing per day. You have 7 OR going simultaneously. Most of the cases are on the urological laparoscopy cases. This is the kind of setting every resident and fellow would dream to be trained in. How the training in the medical field is organized in China? How do you train your residents? So how many years? What's the curriculum?
Actually, in China, for resident training is getting more and more strict and more complicated. Take my own students as an example. For example, the first they must take 5 years, and again 5 years for getting medical bachelor degree, and then they must become my master degree for another 3 years.
Yeah,
and then they must become my PhD degree students for another 3 years. You think it is almost 5, 6, this 11.
11
years.
Yeah.
After 11 years, it's only medical students. not a doctor, not a urologist.
Yes.
And then he went to work in my hospital. He did join a national residence training program first. This resident training program maybe usually is 3 years. It's 3 years.
More, yeah.
Yeah, it's 3 years. And 11 and others is 40 years.
40.
And then he can be a certificated resident in my hospital. This is not a specialist, not a urologist, honest doctor. And if everything going well, he can pass every examination and he can pass every inspection. Then he did another 5 years, another 5 years for training a urologist. And then you see this is 11, plus 14, and another 5 is 19 years. Wow. 19 years, and then
medical studies.
He can become a urologist consultant. This I think is a long way to go.
Okay, then you can go to fellowship for subspecialty, and you can do either stones or laparoscopy, or oncology, or whatever.
This is a lot of 1 or 2 years.
Maybe 2 years more.
Yeah, maybe 1, 2 or in our department, maybe it's 2 milestone disease patient, maybe 1 year is enough. But a lot of center maybe at least 2 years for fellowship, for endourology fellowship.
And you have both clinical and research in fellowship.
Yeah, both. I have both basically research and clinical fellowship in our department, in our center.
The two combined or separate?
This is separate. You can apply
to basic research.
Basic and the clinical together is 2 years.
2 years.
You can apply clinical fellowship only 1 year.
Okay. What's the proportion of fellows you have from foreign countries? You have people from other countries. What's the proportion compared to the Chinese? 1%, 2%?
Actually, for foreign fellowship, for international fellowship and the national fellowship, because according to Indo-Urology Society regulation, is only 1 fellow for basic and the clinical, 2 years fellowship is only 1, and the clinical is only 1. Each year for international fellowship is only 2, but
only 2 you have.
But if you don't need certificate from Indo-Urology Society, you can come to my department. It's 1 month, 3 months for observership. It's okay. You can come.
This is for visiting.
Maybe, visiting. It's okay. It's okay. It's okay. But I think most 1 year, 20 or 25 for this kind of visiting fellowship is okay. 1 month, 3 months is okay.
Okay. What's the typical day you have in your department? You come to the hospital in the morning. So what you do first? You go to surgery. You go to the round to see the patient. You go to the lab for research. How do you start your day? And how,
for me, this for me is how to spend a day. For me, I think for me it's really busy every day, from Monday to Sunday. From Monday to Friday, in the morning, I must go to general hospital for administration work, because I'm a vice president of my general hospital, and I must do a lot of administration works. And then after administration and the workers, and then I can
You
do
come to the
some
hospital.
surgery, and I think average maybe 3 or 4 procedures for me. And then in the Monday afternoon, I go to outpatient department for see some patient. Maybe in one afternoon, I have to see 20 cases.
Wow.
And yeah,
And
and then after work, I must work at the home at least 20 or 1
5.
a.m. I must revise my paper. I must do a lot of academic things for sometimes.
Academic
I must,
research.
this.
Yes, that's interesting. So in China, urologists have modified the PCNL technique since the 1990, using first the rigid ureteroscope, the 8 and 9F, via the 14-18F percutaneous tract provided by facial dilator and matched by peel-away sheet to manage the upper urinary tract. And this was termed a Chinese mini PCNL. As for yourself, you coined another technique called super mini PCNL or SMP. You are the inventor and the designer of the device. Tell us a little bit how the idea came about. What pushed you to do this?
This is a very interesting question. Actually, for mini PCNL, most of urology always worry about how to remove this stone fragment.
Yeah.
Because for standard PCN, you can use basket. You can use forceps remove the stone fragments. But for this is mini, is axis size is only 18 French. Maybe you use basket, use forceps. You must take a long operative time.
Yeah.
Yes, and then most of the American urologists and the European urologists don't like this technique. And then my teacher, Professor Wu Kejun, he is a pioneer of Chinese mini PCNL, and the developer is pump. This is pump. Pump you can push.
Effect,
you can flush. You can flush stone fragments out, and then maybe you can shorten this operative time. And you see, this is part. You use pump, flush the stone fragment out. This is passive. This is passive. Sometimes you flush the stone fragment in the sheath and in the way, and the half is out and half is
stay in the
come back to the pelvis, to the kidney. And then I think you can use suction. Use suction, and then you can, this is active. You suction, and then you can remove this stone very fast. And then I developed this idea. Actually, in this technique, you suction, you must have enough irrigation.
Enough space.
Not enough irrigation, your suction is cannot use you cannot remove the stone fragment. You only suction air, you cannot. You must action water. You must suction irrigation, and then you can remove the stone very fast. Then I wish, because you see, sometimes this is mini nephroscope is really size. Size is small. I work in China is really small. You always use work in China for irrigation China. And sometimes in short probe, in short laser fiber, is free space for irrigation is limited. Then I develop this 2 layers sheath. Irrigation flow in sheath, and then suction flow in sheath. This is one way sheath.
We'll
then
see the movie and
everything is
it
okay.
will explain in the movie.
In this video, we provide a step-by-step guide for the new generation Super Mini PCNL technique, SMP. The basic components of the SMP system are an 8 French militarized nephroscope with a newly designed irrigation suction shoes. The irrigation suction shoes is composed of a straight shoes and a handle. The handle consists of an irrigation port, a straight tube, and an arboric bifurcated tube at 45 degrees. The suction port located at the end of the arboric tube. The straight shoes is two-layered metal structure. The space between the two layers of the shoes function as a channel for the irrigation water, and the central lumen of the shoes works as a conduit for continuous suction. The shoes had side holes at distal tip, which allow egress of irrigation through the irrigation channel. The key feature of the irrigation suction shoes is to allow inflow and outflow respectively. The irrigation is delivered through the irrigation channel of the shoes. Thus, a one-way flow is created as the inflow that comes out of the irrigation channel of the shoes is immediately aspirated through the suction conduit of the shoes. The irrigation can create a vortex at the distal end of the shoes, and active suction can help to draw stone back into the suction conduit to remove it. During the suction, the negative pressure can be adjusted by occluding or opening the pressure vent located in the axis of arboric tube. Now we introduce the SMP technique in one case who had a 1.8 cm stone in left kidney. The patient was placed in prone position. Percutaneous access to selective calyx was achieved under fluoroscopic guidance. The success of the puncture was confirmed both by free flow of the irrigation fluid and by fluoroscopic images. Using a guide wire, the dilatation was carried out with 10 French facial dilator. Then a 14 French irrigation suction straight shoes with an obturator was advanced over the guide wire and introduced into pelvic closure system. After checking the position of the shoes under direct nephroscopic vision, the guide wire was removed and the handle was connected to the straight shoes. The irrigation port of the shoes was connected to an irrigation pump. The arboric tube of the shoes was connected to the specimen collection bottle and brought then to the negative pressure aspirator. Stone fragmentation was accomplished by using Holmium laser with 550 micrometer fiber. The tiny pulverized stone fragments would pass around the scope and evacuate through the arboric sluice. If the stone fragments were too large to pass around the scope inside the shoes, the scope could be withdrawn slowly to proximal to the bifurcation in order to create an unobstructed channel for large fragments evacuation. During the section, the negative pressure could be adjusted by either partially or completely occluding the pressure vent. At the end of the procedure, a single fluoroscopic image was obtained to assess the stone-free status. After removing the ureteric caster and the shoes, the wound was sealed with absorbable gelatin. All stone fragments had been collected in the specimen collection bottle. One day after surgery, a CT scan confirmed the patient was stone-free, and the patient was discharged following the CT scan.
And they use always the laser with this device. You never use the pneumatic.
No, not always the laser. Sometimes,
it depends.
Sometimes in some hospital is not laser available. You can use pneumatic laser chips because pneumatic. This is nephroscope. Working channel is 3.3 French. You can use really small probe. You can use pneumatic laser chips, not only for laser machine.
Yeah. Is this technique reproducible and teachable? Have you teach other urologists how to do it? Is it easy for them to learn this technique?
I think it is really easy to learn for this technique because you can do PCNL, you can do SMP. It's because the puncture dilation is
All
the
these
same.
are the same, yes.
Yeah, it's the same. It's only you only change your mind for remove stone. Traditional PCM process, you remove stone. You remove stone is for forceps basket,
Yeah,
and
that's
for
good.
mini PCM you use pump flush, and for this is suction. It's only this. I think it's really easy to learn this.
Okay. So another innovation you have done recently is the use of this SMP in patient under local anesthesia. This is a very good achievement. We'll add also this movie and this, how this idea came about. What pushed you to do this?
because COVID-19 pandemic and patient don't like stay in hospital too long or overnight. Then I think I can do day surgery for SMB, and then and then the local anesthesia is good because for this elective case, this patient is younger and everything is okay, and then stone is not too large, maybe 2 or 3 centimeters, and simple, and only one puncture, and then the whole operation is no bleeding, no perforation, and then I can to tubeless PCNL, and then patients
excellent
recover very fast, and then
you don't leave even a double J stent. Don't leave any double J stent.
For this patient, you can depend on procedure. Sometimes it's a small stone fragment down to the urethra. I must put a DJ stent because it's stone in the urethra may cause patient's pain and obstruction and fever, and everything is okay. I totally tubeless. No left start tubal, no stent. This is good.
How many cases you have done so far? How many cases you have done so far?
Not too much, maybe about 25 or 30 cases. Not too much. Not too much.
No complication at all.
So far,
no. Great.
No complications so far. Maybe more and more cases, maybe sometimes a complication maybe come out.
Dear friends and dear colleagues, today we talk about super mini PCNL and pilovertebral block anesthesia, an alternative option during the COVID-19 epidemic. I'm Dr. Guohua Zeng, come from Guangzhou, China. As everybody knows, COVID-19 is effective in more than 200 countries all over the world. Only emergency procedures for urologists are allowed in some centers, such as renal colic, acute renal failure, and infection caused by obstruction. And too many elective procedures for urologists are considered or postponed because of safety consideration and the shortage of health resources and so on. Sometimes you meet a very special situation. You have to do PCM procedures, but you know PCNL usually performed under general anesthesia. When you do general anesthesia, you must use ventilators, and then potentially increase the risk of COVID-19 infection. And after PCM procedures, you have to keep the laparoscopic tube or DJ stent, then it prolonged hospitalization and increased the hospital visit for the removal stent. How to manage this issue? SMP and paravertebral block anesthesia is a good example. Okay, next I will invite our anesthesiologist, Dr. Zhang, to talk about this technique.
The patient was placed in a lateral position. After sterilization and draping, scan the patient's back with a low-frequency ultrasound transducer. Place the ultrasound probe in the parasagittal place. Scan the ribs and find the 12th rib. The left side of the screen was caudal and the right side of the screen was cranial. And then move the probe from lateral to medial to image the transverse process. In this plane, the paravertebral space is located between the transverse process of the upper and the lower vertebral bodies. The lower boundary is the pleura, and the upper boundary is the internal intercostal membrane. After infiltration anesthesia with lidocaine, an out-of-plane technique was used for a paravertebral block. When the needle advances into the paravertebral space, inject some local anesthetic. We can see the pleura depression.
Next, I will introduce SMP technique. SMP technique axis size is only 12 and 14 French and with irrigation suction sheath. With this small size sheath and with this continued active suction, and they cause really less bleeding and lower pressure and they cause really less urosepsis. And then with this suction sheath and make stone fragments removal effectively, and then shorten operation time. And after operation, and the patient is totally tubeless, no tubal, no stent, no Foley's catheter, and this real day surgery, and they make a patient very fast recovery, and then no need for extra stone extraction devices, and then greatly reduce medical cost. Okay, next, I will share this case with everybody. This case is male, 37 years old. Right flexible uroscope was performed 1 week ago. You see this left renal pelvic stone 3.2 centimeters, and the CT value is 1,400 HU, planning for SMP. After paravertebral block anesthesia, patient was placed in prone position. You see, this is a pelvic stone. I make a puncture from middle posterior calyx via ultrasound guiding. Oh, you see, I cannot make a tip of needle not clear. Don't worry, it's only move tip of needle forth and back. Then you can see it is very clear. Oh, I get it. Urine is out. Usually, I insert guide wire and make dilation under X-ray guidance. It is very important and very safe. Then I change the 14 French irrigation suction sheath. Usually, I break stone with laser machine, laser setting, or with fragmentation setting, high energy and low frequency, usually 2.5 joules and 20 Hertz. After operation, I must check stone-free blood with X-ray and ultrasound. Then stone-free and remove sheath. All stone fragments in this specimen collecting bottle. I show this stone to patient. Patient is very happy. Then I remove Foley's catheter. This is real totally tubeless, no tubal, no stent, and no Foley's catheter. Okay, patient now try to get up from operation table, try it. Oh, he is successful. Then he sit on the table of and have rest. I try to stand up. Okay, he stand up. And then you see, he can do everything fasting his charges. Then he walked out from OT. After operation 2 hours, patient walked out from his wards and went to radiology department for KUB. This is KUB, no stone left. Next, let us see advantages of SMP under pivotal block anesthesia during the COVID-19. First, very fast recovery. Patients are totally tubeless, short hospital stay, and no need to come back for stent removal, and discharged post-operative 5 or 6 hours. This is real half-day surgery. Second, no risk of cross-infection of COVID-19. For doctors, no need to use ventilators. For patients, 1 day surgery, no need to stay all night in the hospital. The last, the comfortable and the cost-effective procedures. Thanks for your attention.
Another thing, I visited also your laboratory for stone analysis and stone research. Are you doing analysis of every stone taken from the operation theater? Any stone, you do analysis of it for every patient. Are you doing this?
Actually, for most operation, I think we must do stone composition analysis. This is really useful for prevent stone recurrence. But for metabolic evaluation, I must for some elective patients, or sometimes young pediatric little stone and solitary stone and very complex little stone, for example, multiple stone. What about for you for this? Which kind of patient do metabolic workup?
Yeah, metabolic workup usually for patients who have recurrence, they come for several times. So, yeah, but if you have one occasion, you have one stone for maybe 5-10 years, you have there's no need to do metabolic evaluation. But if someone who has recurrent stone, I think it's valid to do this. And what's the most prevalent stone in China? What's the most? Yeah,
I think most common is calcium oxalate. Yeah. Calcium oxalate, maybe more than like 18%. But now uric acid stone is increased in China. Maybe 10 years or 20 years ago, uric acid stone is really low,
so
maybe less than 5%. Now maybe it's up to 15 or 10%. What about in your country? Maybe uric acid is increased or decreased?
Oxalate monohydrate is the most frequent.
Yeah.
Also, sometimes it's a mixture of the whole. But
uric
acid is also increasing because of a change in the diet. People are eating a lot of meat now. So
I think so.
Maybe probably is the explanation why the uric acid is picking up.
Yeah. Because I asked Indian doctor Escapa. In India, many Indian people is vegetarian, and then uric acid stone is not too much.
It's very low. Yeah, the incidence is very low there.
Yeah.
Okay. So you you have shown me last time this new machine you developed to remove the stone from the lower calyx after if you have residual fragments. Tell us about this innovation.
Yeah, this is a very interesting and a very innovation machine. This machine is a physical vibration machine. This is in this machine is a table, and the under table has a
vibrating
is a
device.
Oscillate.
Yeah.
This oscillator you can move in different direction. You can move up and down.
We'll show the movie as well.
Yeah, you can move from right and the left, then you can vibrate. You can move the stone. This stone is free from the calyx, and the larger oscillator is push the stone from the low calyx to the pelvis, and then down to the urolator to the urolator.
Yeah.
For this process, you can see with the ultrasound monitor. Then you can see, oh, stone is free, and then stone in the pelvis, and the people you can. This is very interesting. This is really especially for low post stone after flexible ureteroscope, after shock away, and then patient cannot pass the stone segment.
Yeah, especially for the lower calyx, where it's difficult to get this stone removed spontaneously. So you need some help with this machine.
The external physical vibration resectable EPVL machine is composed of a treatment couch, a sub-oscillate, and a main oscillate. The couch can be tilted forward and backward with up to 30 degrees. It also has both left and right side tilted with up to 15 degrees. The sub-oscillate located on the treatment couch could generate harmonic vibration wave in a horizontal direction that induce the stone fragments to separate from the kidney or ureter and broaden a moving space for the fragments. The main oscillate, which could rotate 316 degrees, could generate multi-directional harmonic vibration wave that provide the axial effect of pushing the stone fragments out. Now we introduce the EPVL technique in a case with renal stone located in a lower calyx. The patient is placed in the supine position, and the couch is modified to a head-down tilt of 25 to 30 degrees that will ease lower calyceal stone fragments discharge. Then the sub-oscillate is used to induce the fragments to separate from the kidney and broaden a moving space for the fragments. During the procedure, ultrasound could be used to monitor the stone location and guide the tilt angle of the treatment couch to assist the stone fragments discharge. After adjusting direction, the main oscillator is applied over the ipsilateral renal calyces with pressure to push the fragments to the renal pelvis. Next, we tilt the supine patient from the head-low, feet-high position to the head-high, feet-low position, and turn the body 15 degrees towards the healthy side. After adjusting the direction of the main oscillate towards the ureter, the stone fragments are progressively discharged from the urinary collecting system.
What's the success rate of this manipulation? Success. How many times you get to flush the whole thing to clear, complete clearance with this device?
I'm not sure, but I published two, maybe 5 publications in different journals in JU, in World Journal of Urology. Maybe about 20 successful rating, maybe about 25 or 20, no, 19.5 or 96%. It's really high. It's really high.
Yeah.
I think it's, yeah.
Okay, great.
Yeah.
So you published a book recently with Dr. Kamal Sarika about stone management, which is called Percutaneous Nephrolithotomy. This new book. Tell us what this book did bring to the management of stone. What's new in this book?
I think this book is only published by Spring company.
Yeah.
You see this book?
I saw. Yes, certainly. The Spring.
You can download this book. Free.
Yeah. Yes, sure. We can.
I think this book maybe you can remove some new management for stone disease. For example, this is basic research, and most of chapter is focused on clinical technique for PCN technique, different PCN technique for micro PCN, for UMP, for SMP, for mini, for standard. Maybe you can go in this book. You can find a very interesting technique. Every technique is very detailed. Yeah, I think it's really useful and really helpful.
It will add something to the
younger urologists,
something new,
senior or junior urologist for stone disease management.
In 2012, you founded. You are a co-founder of the International Alliance for Urolithiasis, now the largest stone alliance in the world, dedicated to research and treatment for stone disease, and maybe now more than 80 countries are represented with 450 urologists. Now we are at the eighth meeting of this organization. The ninth, unfortunately, was postponed due to the pandemic. One was supposed to be in London this year, was reported, and we were looking forward to coming again to this excellent meeting. The mission is to promote research and treatment of stone disease. It became the major platform academic exchange in the field of urolithiasis. What is the secret of success of this organization?
Actually, not a secret, successful secret. For you must know a larger stone disease society. It's named I forgot his name, and this society is only one meeting each 4 years, and then 2012, Professor Ye and Kemo and sit together, discuss, set up a larger stone disease organization, and then for this society, focus for stone disease basic and clinical inspection. Actually, at the beginning of setting up this organization is very difficult. It's very difficult. I must invite a lot of international urologists attend my organization. Everybody know what this is what kind of organization, what kind of society, what blah blah blah. Too many questions, too many confusion, and then I must one by one and send the email and explain this society mission, this society task, this And then for everything, I invite somebody to attend my meeting, attend the workshop, and must pay everything. And now it's getting better. Everybody is
every year
yeah,
it's different.
that,
Everything you see the results of the hard work.
I think a successful secret is you must work hard. You must honest. You must honest. Yeah, this is really important. Because you honest, everybody for me is honest. I think it's really, really important. And then you cannot make money from this
of course,
society.
yeah, but
it's
you make
really
science.
Important. Yeah,
you make science. And you make friends.
make friends, make academic.
How do you
don't
see
make money? This is really important.
Yes, absolutely, absolutely. How do you see the future of the IEA?
I think in the future, in IEU future is bright.
It's bright. It's good. Yes, certainly.
Yes, bright. Because with Professor Ye, Professor Campbell, and me, and the
other members,
make this organization is for academic. Is for make friends, not make money.
Yeah, not profits.
This is okay. This is really important.
Great. Do you have a plan to set up the IAU Training Fellowship Research Center outside China? Maybe one day.
For this,
for this
IAU membership, I must. Your voice not clear.
Yeah.
Pardon?
If you have any plan to set up training and research facilities outside China for the IOE.
Oh.
Yeah.
Yeah. Actually, I really hope do some IOE workshop in out of China. For Morocco or another country, and then I think sometimes you can do some small workshop is limited 20 or 30 urologists, and then you can make discussion. You can see some live surgery, and I think this is good. This is better than bigger conference. Bigger conference you can not make a intense discussion. I think it's good. I hope maybe this year is very difficult. Yeah, and the next year maybe I can
probably
can do some workshop, PCNL flexible and the basic stone-based research workshop in your city, in your country. It's good. You can organize.
Yeah, of course. You're always welcome. Well, Professor Zeng, Chinese researchers are ahead in different fields of science, and if anything new to come in the field of both stone research and stone management is going to be from Asia and from China in particular. So we will stay tuned for more breakthrough, and I am sure you will be sharing this generously with the rest of the world. Professor Zeng, it's always a pleasure talking to you. And before leaving, we will repeat Ye, San, Ye.
Yeah.
Yeah. It's great talking to you.
Me too.
Really
See you, I'm very happy.
Good.